Hey guys, I'm going to take a few minutes to talk about the PICL procedure, and I'm not going to talk about what it is in this particular video, but I had a colleague that reached out, and I've had colleagues before ask me about this, and of course because of my location being in the Denver area, I do see a lot of individuals that have had the PICL procedure done, the PICL, so the injections in the very upper cervical spine. And I do have opinions on this, but they're really non-biased, so that's why I do like to share them, because I do think that the PICL procedure can be beneficial for some individuals. And the more videos you watch, the more that you're going to realize that's kind of my answer for everything. But it's really important to understand that if we want the best outcomes, we have to know what we're working on in the first place. So again, not going to talk specifically about what the PICL is, but for those that are wondering, that already know what it is and they're wondering, should I get this done? Shouldn't I get it done? It's very expensive. And typically what you'll hear now and going in for the consultation is that it's not usually just one, that usually they're finding benefit out of 2 or 3 in a row. And that starts to add up after time. The long and the short of it is I wish it was less expensive, and it could be very beneficial for a lot of people. And there's also other things to consider. So one of the things to consider is the fact of, well, what is upper cervical instability and what's going into the presentation for the individual. So if we're talking about hypermobile EDS and that being an underlying factor, or some sort of, unclassified connective tissue disorder that might be happening, we know that there's other things at play in upper cervical instability besides the cervical spine. So this is really important, because if we have an individual where we think that they're a more mild presentation of hypermobile EDS and they have upper cervical instability, and we think that the PICL might be beneficial, then sure, it might be one and done. The PICL might be something that really starts to change things for them and they have added stability. But if it's more than just upper cervical instability, which it actually usually is, there's more layers that go into it with this condition, that the PICL is one part of the toolbox that could be helpful. So in the study that came out, I think it was 2024, so last year, from Petrucci is the main author on it, that looked at the phenotypes of hypermobile EDS. And this was really interesting because as you look through the phenotypes, they came up with a neurological phenotype as well. But going through some of the other ones, the more mild presentations of hypermobile EDS, what we thought was more mild of, the multiple existing conditions and the anatomical orthopedic presentations, even in that category, 14% had a diagnosis of upper cervical instability. That's pretty significant, actually, compared to the general population. And we're not necessarily saying it's severe versus mild, but that's still like 1 in 10 or more have some sort of presentation of upper cervical spine involvement. So there is certainly an upper cervical spine issue. Okay, so that's number one that we could be seeing in this population. And how we address it is very different. Some might respond very well at that level to standard interventions, physical therapy and things like that. If we look at the classical presentation of hypermobile EDS, so like the moderate severity that they had, they really didn't see a whole lot of Chiari malformation, tethered cord. I think there was maybe 1 or 2 people that had it in the groups. But more importantly, the more moderate we look with the presentation, so we're starting to get into some overlapping conditions that about half of the group had upper cervical instability. So as we're becoming more complicated in presentation and maybe we're having some more systemic issues being added in, we're seeing more of the upper cervical component. So just to start to see more things equal more symptoms, right? And then when you look at the neurological phenotype, which was only about 10-11% of those that had hypermobile EDS, of those 11% though, it was like a raging wildfire of neurological conditions, that there was a huge overlap of upper cervical instability, which I think was like 75% of the people had upper cervical instability. And then we had Chiari malformation, I think, and tethered cord were both like 50 to 60%. That's huge. There's a lot of overlap. And not only that, but they also showed that these individuals, when they came into the neurological phenotype and they're having such advanced neurological presentations, they also had, I think it was 14 different comorbidities that they also reported as well. So this is feeding into the idea that the neurological tissue for some is becoming involved systemically throughout the body. And you can have upper cervical things as well. So it's important to understand, and I talk about this in some other videos that I have online that are long and scientific. Sorry, but the science has to be in there too, because it's a newer topic of this problem with systemic inflammation and EDS. So with all of that to say, if we're thinking about somebody that might have a neurological phenotype of EDS, a lot of neurological things that are happening, and we're thinking about the PICL procedure, right? It's also important to understand that we should be working on systemic inflammation then. It should really be under control, very difficult to do, but we need to be able to do it. And then are we sure that we've ruled out the other contributing factors to upper cervical instability? So is there any pulling or adhesions down lower in the cord? Do we have to worry about adhesions around the brainstem and or Chiari malformation? So we want to make sure, and I always tell people, we don't really know our timelines as providers, because we're just learning all of this, right? Like, we're just learning that, oh yes, all of these things are connected in our patients. We're seeing it. What is the common denominator? It's really hard to pinpoint that one thing in an individual. So we're all just learning. So our timelines are not necessarily the perfect ones, but there is no perfection in all of this, and your timeline is never incorrect. So even if you go in and you're like, if you're listening to this too, and you're like, I have the PICL scheduled for next week, I haven't worked on MCAS at all, or I haven't worked on the chronic COVID load that I've been carrying. It's totally okay, because it's something that you can do afterwards also for better outcomes. But just to understand that there are different layers to be able to work through. And going into the PICL procedure, you want to exhaust all the other anatomical parts of upper cervical instability, because the presentation of upper cervical instability, the severity is based on your clinical presentation, not your anatomical involvement. So in other words, we have a lot of people that have mild to moderate anatomical instability that we can see on dynamic motion x-rays, whether it's supine or upright imaging, and their presentation is very severe. This is a sign that there is a neurological overlapping phenotype that is present that's causing hyperreactivity of that neurological system and probably widespread neurological inflammation. So something that anatomically feels like mild to moderate instability is actually feeling to that patient as a very severe presentation, because the nervous system is hyper-responsive. So that's where we might be able to bring somebody out of, severe form of upper cervical instability into moderate and into mild by actually working on a lot of different things. And it's not head isometric exercises for this population, maybe for mild presentations, but things to just consider off the top of my head would be SI stability, so SI joint stability, pelvic control and stability, because you need a stable base in order to have a stable upper cervical spine. It's like the Jenga game, right? So we have this toothpick, which is our spine, and this giant bowling ball on top. And if the toothpick is sitting on, a wobbly board as well on the pelvis, it's just not a great setup. So we can start lower. So for those that have upper cervical instability, has anybody ever worked on this pelvic control and stability or bracing or anything down in that area? As we work our way up the spine, the diaphragm has a lot to do with control over the suboccipital, so the base of the cranium, and also pelvic control as well, and SI stability, pelvic alignment. So has anybody worked on correcting the diaphragm? Not breathing exercises, not deep breathing, but has anybody worked to correct the diaphragm? Dysfunction that's specifically happening right versus left, posterior mediastinum. It's more than just deep breathing. Going up the spine, has anybody looked to see if there's any occlusion issues? So do we need a bite block to put in to stabilize the jaw work specifically? Vision can actually affect the upper cervical spine as well. Proprioceptive exercises or muscle energy technique with the eyes, there's all of these small little things that we can be doing, head laser activities for proprioception, that don't involve a whole lot of movement to the head, but can help to start to retrain the upper cervical muscles to stabilize the head on the neck. So that's the things that I would start with. So that's where if you have not had a person look from tailbone up to the head and rule out all of these things that might also be helpful, then I'd say we'll pause on the pickle, or we need to talk about these other things afterwards, because I'd rather have you have less pickles, less money spent on pickles if possible, and have better outcomes. So many different factors to go into, especially these severe presentations, which is typically the ones that are getting the pickle procedures. We have to remember to absolutely exhaust all of the other things that we look at. When we're talking about the upper cervical spine, there's so many things to think about. So my personal opinion is, yes, I wish that the pickle cost a whole lot less money, because I do think therapeutically it could be helpful for a lot of people that are experiencing symptoms from upper cervical pathology. And because of that price that's attached to it, and the fact that it seems like people need more than one, then let's pause or figure out where in that cycle that we're going to be able to address all of those other things, hopefully beforehand. And the neurological inflammation, like I said, I have a ton of scientific related videos on this. It's a huge problem systemically in those with some forms of hypermobile EDS that can lead to things like tethered cord and Chiari malformation. And so there's things that we can do for the inflammation that have to be addressed before to be able to have the best outcomes with a PICL procedure. So yes, I do think that it's actually very helpful, but I think that we need to get the timing right, and I think that we need to make sure that we're addressing all of the other factors. We've exhausted all of the other things that could be going into the presentation. So let's go top to bottom, and I'm not going to remember all of them by any means, but just again so you can hear the complexity. Vision needs to be looked at, vestibular issues need to be looked at, any post-concussion type symptoms need to be looked at, jaw stability and reinforcement and occlusion issues need to be looked at. We can play around with the hyoid down here, that tongue tie, oral myofunctional piece. We can go down to the diaphragm, the respiratory diaphragm, and work on that area, look for dysfunction and then correct it. And then down to the pelvic floor, the SI joint, pelvic stability, and work down in that space as well. So if those areas have not been addressed, or just at least talked about to find out what sort of a dysfunction is there, if we want the best outcomes out of the PICL, that has to be addressed with a provider. It's not just about where C1 is sitting. There's so much else that goes into this more severe complexity of upper cervical instability when we have the neurological phenotype in hypermobile EDS. You have to address the other components. You have to address the alignment all the way up, and you have to address the systemic inflammation. So yes, I love the PICL if we can time it right, and if we're working on the other things that are going to be addressed in it. And sorry to also say, but sometimes if you address the other things, you don't necessarily need the PICL in the end. There's other things that might be beneficial for it too. But again, it's a great tool. Let's just time it right.